Okay.
That's awesome.
Okay. All right. So, Ed, what is the normal cerebral blood flow?
So the normal cerebral blood flow is best expressed in terms of mils per 100 grams of brain tissue per minute, and the normal cerebral blood flow is approximately 50 millilitres per 100 grams of brain tissue per minute. This equates roughly to about 15% of the cardiac output, or 750 mils per minute. It's not equally distributed throughout the brain, so the higher metabolically active areas of the brain, the grey matter, receives a greater proportion of the blood flow, approximately 70 mils per 100 grams of brain tissue per minute, as opposed to 20 for the white matter, for the less metabolically active areas. And this is termed flow metabolism coupling.
Okay, excellent. And what factors affect cerebral blood flow?
So cerebral blood flow is affected firstly by the cerebral perfusion pressure. It's also affected by cerebral autoregulation, by the oxygen tension and the carbon dioxide tension, and by the hematocrit.
Okay. And can you define the cerebral perfusion pressure?
Yeah. So the cerebral perfusion pressure is equal to the map. So the mean arterial pressure minus the intracranial pressure. Sometimes people tack on this central venous pressure as well.
Okay.
So your normal values say.
I'm really sorry, Madby's calling
No
me.
problem.
Sorry. Hi, Madby. Oh, so I'm just at some FRCA teaching because I gave Phil Bewley a call and he was happy for me to do that before going to trauma. Catherine is here with me and she has the bleep and she's happy to run across if the bleep comes up goes off whilst we're here at teaching. Is it? Okay. Okay. Sure. It's in the academy, but okay. Yeah, sure, that's absolutely fine. It's it's in the Jenna room just around the corner in the academy. Okay. All right, see you soon. Bye. Bye. She doesn't want to jump, so she's yeah, she said that she's on her way over, so you might cross paths. She said that if you just come out, she'll yeah. Sorry. No, it's fine. Cool, right, sorry, I just want to go back in since we started.
Cut it out of your mind.
Yeah.
Which one of those things that BBC have when they like drop out their thing, like the person with the whiteboard? So cerebral perfusion pressure. Mean arterial pressure minus intracranial pressure.
Yeah.
Normal values. So mean arterial pressure, say your normal is around 90 milliliters mercury. Normal intracranial pressure would be between 5 and 15 milliliters mercury, or 10. So that'll give you a cerebral perfusion pressure. Normal value of around 80 milliliters mercury.
Great. Okay. And how does cerebral perfusion pressure relate to the Monarchy doctrine?
Okay, so the Monarchy doctrine states that the skull is a container of fixed volume, which contains 3 different components: brain tissue, blood, CSF. An increase in the volume of one of these components must be compensated for by a decrease in the volume of the others. Otherwise, it will result in a significant increase in the intracranial pressure. So if you see an increase in the intracranial pressure, so say that it's a 10 or 40, your cerebral perfusion pressure will drop significantly unless you have a compensated increase in the pressure.
Great. Tell me about the cerebral autoregulation.
So autoregulation is defined as the maintenance of a constant rate of blood flow across a range of perfusion pressures. And in the brain, this is best expressed by the cerebral autoregulation curve. So we have cerebral perfusion pressure on the x-axis and cerebral blood flow on the y-axis. And the cerebral autoregulation curve is like this. So the middle bit representing the maintenance of a constant rate of flow at around about, as we talked about, 50 mils per 100 grams. Sorry. And we'll improve the pressure in millimeters of mercury. So maintain at about 50 mils per 100 grams of brain tissue per minute, between around about cerebral perfusion pressure of 60 and cerebral perfusion pressure of 160.
Great.
So this is achieved with the theory is that this is achieved through myogenic mechanisms. So vessel walls sense an increased perfusion pressure, and the muscle in the arterioles relaxes the sort of arterial accommodation with increased pressure to maintain constant flow.
Great. Okay. And what's the effect of CO2 on cerebral blood flow?
So the effect of CO2 on blood flow. And so this again, let's discuss diagram. So we've got PaCO2 on the x-axis, cerebral blood flow in the same units on the y-axis. What we see with cerebral blood flow and PaCO2 is that in the normal ranges of physiological PaCO2, there's a linear relationship between cerebral blood flow and the CO2 level. So as CO2 increases, the cerebral blood flow increases because there's arterial vasodilation. This reaches a maximum around about 8 kilopascals, where the arterioles are maximally vasodilated, and the cerebral blood flow reduces as the CO2 decreases to around about a minimum, around about 3.5 kilopascals, where the vasospasms are minimally vasoconstricted.
Great. And what's the effect of oxygen on cerebral blood flow?
So the effect of oxygen again is similar. So you can chart PaO2 kilopascals on the x-axis and cerebral blood flow on the y-axis. Essentially, oxygen has almost no effect on the cerebral blood flow until you drop lower PaO2 to around about 8 kilopascals, at which point the cerebral blood flow rises.
Okay. And what happens at a cellular level when cerebral blood flow falls below the 50 mils per 100 grams per minute?
Okay. So there's different stages of different rates of blood flow. So at flow rates below 50 mils per 100 grams per minute, you start to see cellular acidosis. Below 40, you start to get impairment of protein synthesis. Below 30 mils per 100 grams per minute, you start to see cellular edema. Below 20 mils per 100 grams per minute, you get the failure of the electrochemical gradient across the cell membrane, and so the ion pumps fail. And then below 10 mils per 100 grams per minute, you see cell death.
Okay, good. And finally, what are the effects of anesthetic agents on cerebral blood flow?
So the effects of the anesthetic agents through blood flow depend on the anesthetic agents. So the intravenous agents, generally speaking, reduce cerebral blood flow and cerebral metabolic rate. The exception to this is ketamine, which will increase both. The volatiles uncouple that flow metabolism coupling that we talked about before. So they will decrease your cerebral metabolic rate, but they will also cause significant vasodilation and thus increase your cerebral blood flow. This is a dose-dependent effect. So generally at a MAC of around about 0.5, the reduction in cerebral metabolic rate outweighs the vasodilator effect. So you have a net decrease in cerebral metabolic sort of demands. Whereas at MACs around about 1, the effect of the vasodilation prolongs. You have a too much increase in flow.
Okay.
And this effect is worse with halothane. Halothane is particularly bad, but that's why we use TIVA in neuroanesthesia.
Okay, great.
Nitrous oxide will increase both the cerebral metabolic rate and your cerebral flow, generally avoided. And opioids have no direct effect, but might cause an indirect effect by increasing your PaCO2, and thus increasing cerebral flow indirect.
Okay, great. I think you got through that in like 8 minutes.
I should have written more.
No, it was great, really good.
Lovely. So that's the kind of the stuff that comes up. And I actually got asked about it. Fiverr, which is why I put it in statements. I just did it. So, grand. I've got the usual bits.
Hey.
Got some MCQ. Sorry, just missed the talking through the questions. And yes, we're just talking around some stuff.
Oh, go on then. Yeah.
You're welcome to stick around. So I couldn't get the main screen to work. I'm sorry. If you guys want to scan the thing and vote, you can. And I'll put it up on there. I'll look out the way.
I thought I was working recently.
Get any phone.
Yeah.
Yeah.
Yours is quite good, isn't it?
Yeah, it's
It's
11.
got the 2
Oh, wow.
Yeah.
Get a 12.
Yeah.
You've got 12. No, mine's
She's just on
yes.
commission.
Yeah.
Yeah, it's not working. It's annoying.
Okay. You can always go. You can go to the website and put in the number. So if you go to slido.com and put in the number, you can do it there, or just join in, however you want. Cool. So take a couple of minutes and read through those, and we'll talk through them. There's a lot of questions on CSF in the MCQ. That way up, that's on this side. Yeah, happy. You can't remember it. It's amazing how quickly it goes. It's terrifying. Cool. Okay, so what have we got? We've got cerebral spinal fluid is produced at a rate of 150 mils a day, roughly. I flip the numbers. So you have about 150 mils total volume. It's produced at around about 500, 550 mils per day.
Oh.
So you turn it over 3 to 4 times a day. They love the concentrations of stuff, and you guys look like, on the whole, you got that right. So more chloride, less glucose. Can anyone remember which things there are more of and which things there are less of? Protein?
Less protein.
Less protein. pH?
Lower.
Lower because there's less protein. So what's the relevant, how does that link in? Remember?
That's why there's more chloride to.
There's less buffering capacity, basically. There's less buffering capacity if you've got less protein, so that's why your pH is a little bit lower. There's slightly less calcium from memory. Sodium is more or less equivalent, potassium is slightly less, but not significantly. Glucose is obviously lower. We test that all the time, don't we? So it's mostly absorbed by the spinal arachnoid villi. Can anyone, and then circulates through the electrical edge? Everyone got that one right, that's good. Who feels comfortable talking through the production, flow and absorption of CSF? Anyone feel like taking the punt? That's
Through the choroid plexus.
so producing the choroid plexus, yeah, absolutely. So that's the lateral, the walls of the lateral ventricles.
Yeah.
Where does it go from there?
To the brain and
Perfect. Yeah, exactly. Into the
third actually.
great, and
And
then
then through the cerebral aqueduct.
Sylvian. Yeah,
Sylvian aqueduct.
yes, into the fourth.
fourth.
Great.
And then out through the Lushka Magendi.
Yeah, brilliant. Perfect.
Oh,
Yeah.
Absolutely nailed it.
Absolutely.
great work. Great work.
Yeah.
I'm well. I need to go on Thursday, so.
So pretty good. Both OSCE and Viva fodder talk through the production, drainage, CSF, that sort of thing. Reabsorption does occur in arachnoid villi, but it's mostly not in the spine. I think there's about 10 of it that happens in the spine. Most of it is in the cerebral, just adjacent to the dural venous sinuses. In the sagittal sinuses. Yeah, exactly. So most of it occurs intracranial, the reabsorption. So yeah, that's just patterns that have come up for my memory. Grand. Happy? Static. Intracranial pressure questions. Happy enough?
Yeah.
Grand. Okay, so I reckon that all but the middle one are true. So we talked about normal intracranial pressure between 5 and 15 millimeters of mercury. Thought about being a bit mean and putting centimeters of water instead, so just always make sure you look at the units, but they're similar enough actually that you probably couldn't make too big a difference. So when can intracranial pressure rise as high as 50 millimeters of mercury normally in physiology?
Valsalva, no.
Coughing, streaming and stuff.
Yeah.
So if you're coughing, it can transiently increase at that level. So that everyone suddenly coughs. The third one might be a bit controversial.
It's got can in it, so I went true in my head.
Yeah. The book I was reading when I was doing the revision and reading the questions said it can only be invasively measured. Then subsequently a bit more reading has said that you can almost clinically estimate it. So I suppose you could argue that that's true.
That's it. It's can you clearly, but yeah.
So I think that might be controversial. So
But is it useful?
happy to accept argument on that.
It's-
But officially, so I think what I was trying to get at with that question was more that you can indirectly estimate or directly measure cerebral blood flow, but not intracranial pressure in routine practice. So intracranial pressure has to be invasively measured. Can anyone tell me how you would measure intracranial pressure?
They can put a little singing, can't they?
Yeah.
I guess
Yeah.
Yeah, that's the one.
Yeah.
Thing.
Yeah. So-
It's the ICB.
So 3 places anatomically that they will put something to measure it will be a ventricular catheter, so through a ventriculostomy through a burr hole, usually frontally. That's the gold standard, the one they use most often, and that's the way they can also take off CSF through that or administer drugs. So that's the main one that they use. You can put an intraparenchymal monitor that uses a clever fiber optic cable and a reflection thing that varying amounts of stuff gets reflected back to the detector transducer, depending on the intracranial pressure, very clever. And then there's a subdural pressure monitor that's pretty much out of routine practice now. Those are the 3 ways I found that might be. Grand. A critically elevated intracranial pressure can cause hypotension. Everyone thought that's true?
It can.
It can. So can is usually like, can is pretty much always true, isn't it?
And may.
And may, exactly, yeah.
That would be just coning, right? Because you'd
Yeah.
initially have hypertension, and then at that point you.
Exactly. So what's the mechanism of hypotension?
The what? Sorry.
What's the mechanism of the hypotension here?
Loss of loss of reflex.
Yeah. So as you cone, your brainstem is pushed out
Yeah.
through the foramen magnum, and you
Yeah.
get compression of the vasomotor center in the middle.
That's
So
what I
that's,
said.
yeah, exactly.
But that would be after. It would no longer be critically elevated because
You'd be dead.
you've coned. I've rated it now.
I'm not sure it gets any more critically elevated than actively coning,
Yeah.
to be honest. And then a raised intracranial pressure may cause pupillary dilatation by the compression of the 3rd cranial nerve. I did think about the mean and put 2nd or 4th or something.
Yeah, I mean that's what I was.
That's the
I had in my hands. So I was like, oh,
Which one?
finger is it?
Everyone's going, oh, to touch and feel. And,
Yeah.
but yeah, it is optimal. So intracranial pressure can cause a variety of cranial nerve palsies, obviously, but this is the most common one. And obviously, a lot of check for the reflexes, so it's important to know the physiology. Then we'll look to the last one. You look quietly confident, aren't you?
No.
That's just terror. All right, grand. So,
It's mean, isn't it?
cerebral perfusion pressure is equal to cerebral blood flow multiplied by cerebral vascular distance. Who thought that was true? Almost no one. It is Ohm's law. It is the other way of expressing cerebral perfusion pressure. So that is saying pressure is equal to flow times resistance. If you get rid of all the other words, that's obviously true, isn't it? So the other words are all distractors. So yeah, that is a bit mean. Sorry, but it's just the other way that it's expressed. Grand. What's next? Autoregulation curve is shifted to the right in the NH. It's shifted to the left. So on your x-axis, the left is lower blood pressures and the right is higher blood pressures. And what kind of blood pressure does the NH have? So that's the easiest way to think about that, isn't it? When is the autoregulation curve shifted to the right? Exactly, that's your chronic hypertension, the classic thing. Grand. A cerebral blood flow of 30 to 40 mils per 100 grams per minute results in edema. That's just that list I was talking through where you've got 50, 40, 30, 20, 10. And you just, there's different things that happen at each stage, and that's quite easy to write MTS on, isn't it?
Yeah.
So 50 was cellular acidosis. 40 was
Protein.
protein synthesis. 30 was
Is it that?
edema, cellular edema. 20
Some,
Yeah.
Oh,
Yeah, and no, actually.
electrical gradient.
Electrical gradient stuff. So it's electrochemical failure basically. So all your
Between
ion,
us, we make an excellent
Exactly, yeah.
exam candidate.
so all your ion bumps around about 20. If you think about that, it's like that's probably one of the last things to go with it. And then 10 is obviously cells start dying.
Irreversible.
So you can work out like a bit acidotic, like you are when you go for a run, and death. And then the other three are kind of in the middle, aren't they?
It's filling the gaps.
Exactly. You can kind of work it out because impaired protein synthesis probably happens earlier than electrochemical failure, doesn't it?
Yeah.
Start to just again, that's just easy to run question on. Hypoxia results in cerebral arteriolar vasoconstriction. Yeah, so I've said vasodilation there, it results in vasoconstriction, isn't it? Yeah, so again, just make sure you slow down the exam, read the things. And then white matter has proportionally higher blood flow than grey matter. I would assume you all got that right, because obviously white matter is your myelinated bits, isn't it? So it's your conduction bits of the nerves rather than the bits that are actually doing all the work. Grand, that's all I've got for you.
Thank you.
Good stuff. Thanks very much. Thanks for coming.